This is Dr. Andrew Morse, bringing you Community Hospital Surgical Weight Loss Program seminar. The purpose of this is just to introduce you to weight loss surgery, to kind of get the ball rolling, and this establishes sort of the game plan moving forward as we begin the journey towards weight loss surgery and beyond. A little bit about myself. I was born in Portland, Oregon, raised in San Diego. I did my undergrad at Brigham Young University. I did serve a 2-year church mission in Chile, so I'm fluent in Spanish. I went to medical school in Kansas City at Kansas City University of Medicine and Biosciences, College of Osteopathic Medicine, and very much enjoyed my time there. I was able to do my general surgery residency in York, Pennsylvania, which was a great place to train and also close to a lot of the big centers in medicine on the East Coast. I got to spend a little bit of time at Johns Hopkins Bayview for burns. I got to go up to University of Maryland shock trauma for my trauma rotations, and then up to Memorial Sloan Kettering in New York City for surgical oncology. And so I really felt that environment gave me a great opportunity to have a well-rounded education. I'm married and have 4 children. First off, just a quick introduction to Christy, our program coordinator. You'll see the slide of her pre and post-op. She's a sleeve gastrectomy patient. You can see the excellent results that she has had. To get started here, I wanted to introduce a few members of our weight loss surgery team. First off, Julie Schwartz is my PA. Christy Hale is our program coordinator and navigator. Morgan is one of our is our assistant navigator. Sandy is our dietitian. Mindy is one of our medical assistants. John Gustafson is our psychologist, and Nancy is another one of our dietitians. Michelle Jean-Jacques is our data analyst, the numbers cruncher. So when we got into weight loss surgery, we wanted to make sure to do it right. We assembled a whole team of people, as you've seen, and those are just a few members of our team, but we've assembled a whole team of people to help make sure our patients have the best chance of being successful for the long term. Our program includes education, behavior modification, dietary guidance, and physical fitness. I am one of those parents who will shamelessly interject pictures of their children and family throughout the presentation. This is our dog, Douglas. He is an Australian Shepherd and full of energy and loves to go fishing with us. Our philosophy when it comes to weight loss surgery, we understand that weight loss surgery is a great tool to get the weight off and keep it off. It's not a magic bullet. It does take effort on the part of the patient. We want our patients to have all of the other tools to help them be successful. We want our patients to have realistic expectations. I always say it's not our job to make supermodels out of everyone. We want people to live happier and healthier lives. We want to make sure our patients are good candidates for the surgery, that they've done those things which will help them be successful in surgery. We want our patients to agree to be active participants in their care, to follow the rules for long-term success. And our patients are certainly our heroes in the process, not us. We're here to help them and support them for the long term. What is obesity? Well, the National Institutes of Health identified obesity as a chronic life-threatening disease where excess body fat results in many serious health problems. There are at least 30 different health problems related to obesity. It is not a lifestyle choice like skinny people think. No one chooses to be obese. On this graph, you'll see that obesity is increasing in America. If you look at the graph in 1991, the heaviest states in the nation ranged from 15 to 19% obesity, and there were only a few. Fast forward to 2010, and there are several states, particularly in the South, with obesity rates greater than 30%. Fast forward one more time to 2017, and they've changed the color scheme altogether, and they've had to create a greater than 35% obesity rate, which was unheard of before. You can see much of the nation has obesity rates of greater than 30%, with Colorado still being the thinnest state in the nation at just over 20%. The other holdouts staying in that 20 to 25% range are Hawaii and Washington, D.C. I think most of you would agree that it's kind of unusual that Washington, D.C. would be in the lower weight category, as we kind of think most of them are full of it. This is my youngest son after his fourth Super Bowl win for the Redlands Chargers. So when we talk about obesity, we talk about in terms of a body mass index. That's a fancy calculation that's done for us, and it's not perfect. It doesn't take into effect muscle mass or bone structure or anything like that. I think a lot of the premier running backs in the NFL would probably be considered obese if you look purely at their BMI. But basically, it is what the insurance companies use, so it's what we have to use. When you look at this graph, you'll find height on one axis, follow that across to weight, and then from there you go straight to the top of the graph and you'll find an estimate of your BMI. So height across to weight, straight up to the top, and the BMIs are all listed across the top. Even though BMI is not perfect, we do know that in general, as a patient's BMI goes up, their risk of mortality or death goes up as well. This is a picture of my daughter after climbing Gray's Peak, one of two 14ers she climbed on that trip. We try to stay active in our family. Obesity is an epidemic, like we were talking about. About 3/5 of Americans are overweight or obese. Adult obesity has doubled in the last 20 years. There are about 300,000 premature deaths annually related to obesity. If you compare that to smoking, where there's about 400,000 deaths, but the rates of deaths from smoking are going down because, in general, less people are smoking. You can also compare that to 90,000 deaths per year related to colon cancer and breast cancer, and you can see what a big problem obesity is. About 3/4 of obese children will eventually become obese adults. What causes obesity? Obesity can be caused by genes that you inherit from your parents. There's certainly a strong biologic component to that. It also can relate to your metabolism, or how your body turns food into energy. Certainly eating and exercise habits can contribute to that, as can psychological factors. Environment certainly is another thing that can contribute to obesity. I think, like Lucille Ball, I would do a terrible job at keeping weight off if I worked in a chocolate factory, for instance. In general, you can see the trend in America of the supersizing of foods. 30 years ago, you can see the size of a bagel at 140 calories versus a bagel you might get now at a bagel store. A plate of pasta that you might have gotten at a diner 30 years ago at 500 calories versus a plate of pasta at a restaurant today would usually top well over 1,000 calories. And there's an example of a sandwich you might have made at home 30 years ago versus one you'd get at a sandwich shop today. We know a person who works at Starbucks and has a customer come in that orders a venti white mocha with steamed heavy cream, and they've calculated the calories in that out to over 2,000 calories per day, or in other words, more than the daily average allowance of calories that the average American should have. As shown by these pictures, my family loves the outdoors. We do some hunting and fishing, and really like getting out. And that's one of the things that's helped keep us safe and sane during the COVID pandemic, is being able to get out and enjoy the outdoors together. When it comes to treating obesity, there are several modalities, including diet and exercise. There are weight loss programs out there, things like Jenny Craig and Weight Watchers. There are appetite suppressants or medications. Counseling has shown some degree of success. There are even alternative medicine approaches, things like acupuncture or hypnosis. Of all of those, bariatric surgery is the best at getting the weight off and keeping it off long term. It has by far been proven to be the most successful. This next slide shows the many medical complications that are related to obesity. Some of these are things you would think would be obvious that would be related to obesity. Things like diabetes and high blood pressure, heart disease, high cholesterol, things like that. Others are things you wouldn't necessarily think would be related. Things like gout, vein problems in the legs, even fertility problems, and even cancer. You can see all of these cancers have a greater risk in obese patients, including breast, uterus, cervix, colon, esophagus, pancreas, kidney, and prostate cancer. Now this next slide shows the good news. This shows the improvement or resolution of many of those obesity-related problems after weight loss surgery or bariatric surgery. And again, some of these things you'd think would be obvious. High blood pressure is 52 to 92% resolved after weight loss surgery. There's at least an 82% risk reduction for heart disease. Diabetes certainly improves. Type 2 diabetes is 83% resolved after weight loss surgery. And then there's other things that you wouldn't necessarily think about. Again, we talked about gout earlier, 77% resolved after weight loss surgery. Another thing that I wouldn't have necessarily thought would be related to weight loss surgery is migraines, 57% resolved after weight loss surgery. And in many cancers, there's a risk reduction as well. This is my second oldest son getting ready to fly with his grandpa. His grandpa's a retired Air Force colonel and retired United Airlines pilot. And was able to safely fly 100 missions over Vietnam. And we're very proud of him. When it comes to the surgeries now, basically all weight loss surgery is done laparoscopically. So it is extremely rare that we do the old-fashioned open surgery. Laparoscopic surgery means, we make a few small incisions, we put plastic tubes through those, blow air in, CO2 to be exact, and we fill the belly up with air. We then put thin instruments and a camera through those different plastic tubes, and that allows us to do the surgery in a minimally invasive fashion. There are a lot of benefits to laparoscopic surgery. One of the benefits is that we have less wound problems, less risk of hernias and wound infections. There are less heart and lung problems. And actually, as a surgeon, I have a better view of the anatomy. I'm looking at something relatively small blown up to 2 or 3 times its normal size on a giant flat screen high definition monitor. So it can very much be helpful in seeing during surgery as well. So we'll talk about 3 basic weight loss surgeries. The first is the gastric band, and I mentioned this for basically historical context. We aren't doing the gastric band right now. Another name for the gastric band is the lap band. It is how I got started in weight loss surgery, but since the sleeve has come along and been shown to be safe and effective in general with better results than the band, we've actually stopped doing the band. One of the problems with the band is, unfortunately, despite a great job in surgery, eventually many patients would develop a situation where the band would slip up or down and would no longer work correctly, or the band actually had the chance to erode through the wall of the stomach, creating a perforated ulcer. Luckily, that last complication is quite rare. We would also have to adjust the bands frequently, which was often very difficult for patients having to come back to the office frequently for band adjustments, especially those that lived out of town. It became quite cumbersome to many patients and became a disadvantage. So the next surgery I want to talk about is sleeve gastrectomy. This is the most popular weight loss surgery in the U.S. It accounts for about 60 to 75% of the weight loss surgeries done currently in the U.S. With the sleeve gastrectomy, we staple up through the stomach and remove 2/3 of the stomach. That leaves about 1/3 of the stomach left, or roughly the size of a medium to large banana. That limits the amount of food that patients can eat, but it also removes the part of the stomach that produces ghrelin, which is the hunger hormone. So by removing that, most of our patients eat or most of the patients eat because they know they're supposed to, not because they're hungry. Some of the other advantages of the sleeve gastrectomy is it's much less follow-up intensive than the lap band was. Disadvantages are it's not reversible. I'm not sure why anyone would want that reversed or why they would want that stomach reimplanted, but obviously that's impossible. Also, there are rare complications such as worsening heartburn. Most people who have the sleeve gastrectomy, their heartburn gets better, but there are patients that develop worsening heartburn on occasion, and that could require another surgery to need to be done. This is me prior to weight loss surgery back in September of 2018. I've lost about 70 pounds and am very happy with my decision to undergo weight loss surgery, and I'm confident that you will be as well. So the next surgery I want to talk about is gastric bypass. The gastric bypass has been the surgery that's been around the longest. It involves rerouting the small intestine and creating a little pouch of the upper part of the stomach. So basically we staple through. Oh, someone's at the door. Just a second, I'll be right back. All right, let's get back to work here. So, where was I? So we staple up through the upper part of the stomach, creating a little pouch. And then we reroute the small intestine. We divide the small intestine, bring one end up and hook it to the stomach, and the other end plugs in further down. That creates kind of that creates that little Y look. That's why they call it a Roux Y. And so the part hooked to the stomach brings the food down into the intestine. The other part of the small intestine brings in the digestive enzymes from the liver and the pancreas that help digest food. And until the enzymes get together with the food, there's really not much digestion or absorption. So there's a shorter distance for that digestion and absorption to happen between where the parts of the Y meet up and the end of the small intestine. There are potential side effects of the gastric bypass. You'll notice on the slide that dumping syndrome is listed both as a pro and a con, or an advantage and a disadvantage to gastric bypass. Dumping syndrome is when fats and carbohydrates get into the small bowel without being very well churned up by that little pouch of stomach. The small bowel is not used to that, pushes them through really fast, leads to crampy abdominal pain, diarrhea, lightheadedness, nausea, and vomiting. Sounds like a disadvantage. The advantage is it is foods that are very high in fat and high in sugar that tend to cause dumping syndrome. And so it very much encourages patients to avoid those types of foods. In general, gastric bypass is great at controlling reflux. The reason being is most of the stomach acid is made in the lower stomach. And if you see in that drawing, the lower stomach is then separated from the upper stomach, and acid cannot wash back up into the esophagus anymore after the surgery. Other complications include the risk of leaks at any of the different connections, internal hernias, and the potential for malabsorption. There is definitely some malabsorption with the gastric bypass. Most people are able to counter that by taking a chewable multivitamin, a chewable calcium with vitamin D, and a sublingual B12. So it's very rare that we encounter any problems with malabsorption. So in general, these surgeries are very safe. If you'll notice, in general, most people say that if the gastric bypass is the gold standard, the one that everything's compared to, the sleeve gastrectomy is about twice as safe. And the lap band was about 4 times as safe, except for down the road, more lap band patients ended up back in surgery than sleeve or bypass. But even gastric bypass is very safe. It's about twice as safe as a hip replacement, 4 to 15 times safer than a bowel resection, and 25 times safer than a heart bypass. What are the expected results of surgery? In general, studies have shown that after lap band surgery, people would lose about 50% of excess body weight And after the sleeve gastrectomy and the gastric bypass, people would lose around 60 to 80% of excess body weight. Those are just averages. We have some people get back to completely normal weight. We have other people that lose 30% of excess body weight and are ecstatic that they've done that well. These are my two oldest boys who are living in Utah. One is going to Utah State, and the other is working as a fishing guide on the Green River. In general, patients are recommended for weight loss surgery if their BMI is over 40 or if their BMI is over 35 and they have an obesity-related health problem. These surgeries are shown to be safe down to a BMI of 30 or even 27 in some studies, but most insurances don't cover weight loss surgery below a BMI of 35. Obviously, patients have had a history of being overweight. They've made other attempts at losing weight prior to deciding on weight loss surgery. We also want to make sure our patients don't have any untreated diseases that cause them to be overweight. For instance, hypothyroidism. If someone has low thyroid level and they didn't know it before and it's not being treated with thyroid hormone replacement, then certainly we would want to replace their thyroid hormone and get their thyroid hormones where they need to be and see if they lose the weight that way first. We want to make sure that patients are not drinking alcohol in excess or using tobacco or have other drug addiction problems. The hospital has a policy that we cannot do weight loss surgery on a patient who is using tobacco or using marijuana within 6 months of surgery. So encourage anyone that are using any of those substances to stop them immediately so that we have plenty of time to get that 6 months in and get you to surgery. Let's see, we want patients to be prepared to attend regular follow-up sessions and to make lifestyle changes. At this point in the live seminar, we would ask if there's any questions. Please feel free to get us any questions you have. We have several great folks on the team that can answer those questions. Myself and Christy, who have been through the process. Sandy's our dietitian and does an excellent job. And Julie, our PA, and Mindy, our medical assistant, among others. So we'll try to get any questions answered that you might have along the way. A couple other slides to cover. The 10 rules of, or 10 important rules of weight loss surgery success. Make sure to eat small meals, eat slowly, chew thoroughly, stop eating when you feel full. And I would say many times it's good to stop eating before you feel full. Usually that full feeling will really kick in about 20 minutes after eating. And if you eat until you're full, you'll probably find yourself feeling overfull 20 minutes later. Stop eating when you're satisfied or before. You'll pretty soon get to be able to judge about what is the right amount of food. Try not to drink while you're eating. Attend follow-up appointments. Make sure you're getting at least 64 ounces of low-calorie, non-carbonated liquids every day. Make sure you're getting at least 60 to 80 grams of protein a day. Follow your nutrition guide. Try to get 30 minutes of exercise each day, or at least on average. And then attend the support group. Support group is not required, but it is a great group of folks and is a great way to help along the journey. Well, the next steps, Christy will work on insurance verification, and we'll find out what your insurance requires in order to get to surgery, kind of the hoops that the insurance company makes you jump through to be able to get to surgery. We'll then contact you and go over that. We'll get you a consult with the surgeon. We'll then arrange the team visits. Everyone has to meet with nutrition, psychology, and sometimes exercise physiology prior to surgery. We'll do some pre-op education, make sure you're ready for surgery, and then get you to surgery. There are some insurances that don't cover it, and for those there are cash pay options. And Christy can talk to you more about that in general or with specifics. There are some appointments along the way that may not be covered, things like nutrition visits and psychology visits. Some insurances cover those and some don't. So we'll try to keep you informed of that, but it varies so widely between insurances. If you have any questions, feel free to call our weight loss surgery office at 970-242-9123. And that's it. Thank you very much for your time, and we look forward to working with you and helping you to live a healthy and happier life. Be safe, and we'll see you soon. Thanks. Bye.